Hello, my name is John Stone. Thanks, Mark and Zarina, for inviting me to speak. I really appreciate the offer. Very similar talk. Zarina talked a lot about upper extremity double crush. This is basically a lower extremity version. When you're first confronted with a patient who has a foot drop, you get this flood of differential diagnoses that run through your head. And it could be lots of things. It could be paracentral lobule in the brain. It could be an L4-5 disc herniation. And the one thing that I believe is usually looked over is perineal nerve entrapment. And that's kind of my goal today, is just to increase the awareness of this nerve. And like a good doctor or provider, I'm sure you start by asking the patient questions. As we all say, the clinical history is really one of the tenets of how you figure this out. But the reality is distribution of pain in the affected limb is very unreliable. And this study was looking at the sort of pain map that patients report with L5 nerve root, and you can see it's essentially the entire leg, including the bottom of the foot, which we typically think of S1 and not L5, and so it could be hard to know. Anterior thigh sometimes hurts with L5, at least in the study. And so then you move on. You say, okay, I'm going to be a really good doctor. I'm going to look for sensory deficit. And not every patient has a sensory deficit, but if they do, it can help you. But again, there's so much overlap between L5 and perineal nerve on the dorsal foot and lateral shin that it can be really still hard to tell. So you're going to say, I'm even better. I'm going to test inversion and eversion, because that's the classic answer. And if you have that, it makes your life way easier. So if they have preserved inversion, but only eversion weakness, that's consistent with a perineal neuropathy. Whereas if they're weak in both, that's more likely to be a radiculopathy from L5. But the studies show that our understanding of myotome innervation isn't actually as good as we hope, and there is an overlap between what L5 does and which muscles it supplies. It surprises me that we don't diagnose this more, because if you think about where it's located in your leg, how susceptible it is to external trauma, and the other syndromes that are similar, I feel like it should be more prevalent than we actually report. It's overall the third most common entrapment syndrome. It's the most common in the lower extremity. And this whole business about double crush is still unclear. If they have an L5 or DIC plus a nerve, does that make their situation worse? I personally believe it does. I think that a patient is much more likely to have a foot drop if they have a disc and an entrapment than if they have one alone. So this is a good example of a case that can throw you off. A 78-year-old male who has a bunch of spine surgeries in their history, came in with a foot drop after travel to New York City from Rochester, where I'm from. So 6 hours in the airport or so. And basically he developed numbness on his foot, and he's had low back pain forever. He's had lots of spine surgeries. On his exam, he had weakness of the eversion, but preserved inversion. So that's the telltale sign. But I'm a fan of 10Ls. I know the sensitivity of that test isn't great, but if you tap along the course of the nerve, sometimes you'll get surprised. Sometimes that nerve will really sing, and the patient will say, ooh, that's tingling in my foot, and it can help you lead you into that diagnosis. So here's the spine, and you can see how crushed that L5 nerve is. I mean, there is no foramen, for that nerve to go through. And any kind of spine surgery in this elderly person with multiple prior spine surgeries and chronic back pain is going to be a huge operation. And I'm not saying that it doesn't need to be fixed, but what I'm saying is it may not be the current problem that he's seeking my care for. And so, of course, you get an EMG because, well, there was no pain with it. That was the other telltale sign. And he had a Tinel sign. So I wanted to confirm my suspicion that this was the perineal nerve. And the biggest thing that I look for is a conduction block. So if there's a different speed of the nerve above the knee and below the knee, to me that's the best prognostic indicator, but also the most suspicious. Because when you look at the EMG data, sometimes it'll look hot everywhere, because he does have 5 root impingement. So he's got tensor fascial lata, which is above the knee, but still has spontaneous activity there, indicating that he does have a 5 radiculopathy. So you're going to get a mixed bag in the EMG, but a conduction block across the joint is going to give that away. And like Zarina said, ultrasound is a fantastic tool for confirming your diagnosis. His perineal nerve at the fibular head was 17, versus higher up in the leg was 7. And so with the conduction block and the increased cross-sectional area and ultrasound, that's basically the diagnosis. The really cool thing about this is they get better a lot, very rapidly, and I feel like it's a better outcome often than some other types of surgeries we do. So he already had a 4+ dorsiflexion in his first post-op visit, which is, he was in an AFO before, so that's a great outcome. This is what the surgery looks like, and this isn't how I do it. The surgery that I do is basically much smaller than that. Basically, 3 of the hash marks in total is the entire operation, but I put this up there just so people can see the anatomy. And you can see in image C that nerve just entering the peroneus longus fascia, and that's the entrapment point that we're talking about. And a lot of us don't think about it, but it's exactly the same as cubital tunnel syndrome, exactly the same as carpal tunnel syndrome. It's entering through a fascial hole, and that can become too tight in some patients. Just another case to kind of further emphasize how sometimes out of the box you have to think about this. 75-year-old who came to my office, or actually in the emergency room, he had severe back pain after MSSA endocarditis, and essentially they found that he had a large mid-thoracic epidural abscess. And fortunately, with antibiotics and time, this completely resolved. But in just seeing him in routine follow-up, 3 months after his initial presentation, all of a sudden he's got foot drops. And he didn't even realize, but he was like a grade 1 on the left foot and like a grade 3 on the right foot. And I'm like, that's interesting, no pain. It's got to be your cord, right? Like, because he had an epidural abscess. So I repeated the MRI, and that one was actually clean. And I got an EMG because he did have a Tinel sign, and he had weakness of eversion, but not inversion. So I was suspicious of the peroneal neuropathy. Now, he had lost weight with this. He crosses his legs. He had some other things, but he had this conduction block, 31 down to 9, and then his nerve was large on the ultrasound. It was 19. So I just got this result Tuesday, so I'm going to offer him a peroneal nerve release. He doesn't have an outcome yet, but just in summary, L5 radiculopathy is more common than peroneal neuropathy. So I'm not trying to say everything can be cured with this nerve, but you got to be suspicious about it. The differentiator that you're looking for, if you have this, it's really nice. Inversion is preserved with peroneal neuropathy. I like provocation, tap of the nerve, try to manipulate it. If it gives them symptoms, you might be onto something. EMG and ultrasound should be used in combination to confirm the diagnosis. And sometimes if you're still not sure, you can get a popliteal or mid-sciatic block, especially if most of the symptoms are pain, to help differentiate radiculopathy versus peroneal nerve entrapment. The nerve release is a quick operation, takes about 20 minutes, it's effective, and has low morbidity. So sometimes I'll start there if I'm confused about the diagnosis. Thank you.